feedback that received from you. So, all right. So here we'll start the first of these series of renal rounds. So we are going to discuss the science and art of clinical decision making. We are all physicians. Here, these are surgeons. So the surgeons do most of their work in the operating room. They do very heroic surgeries. They are able to perform things that can change the lives of patients. But that is not something which we physicians do. Most of the physicians' work is done in this environment. This is an environment in which we discuss with each other, we talk to the patient, and we do the process of decision making. Often it happens during ward rounds or it happens during interviews with patients. So why is this important? Uh, I think making a diagnosis is really very important because many times the way we diagnose a condition is pretty analogous to this elephant and the blind men situation, where depending on which part of the elephant you are touching, you make a different interpretation of what you are looking at. So I think clinical decision making is the process. If you want to define it, it is a process by which we determine who needs what, who in this case is our patient, who needs what and when. Why is this important? Because diagnostic errors, it may come as a surprise to you that diagnostic errors are responsible in most developed countries for about 20% of all adverse events amongst hospitalized patients. So, and they're responsible for their third leading cause of in-hospital deaths. So, how do you do the clinical decision making? Clinical decision making requires you to compile your own data. I think your own data is essential, that when you talk to the patient, you go through a process of data gathering. And using that data, you construct an argument for a particular disease state based on your interpretation of the facts. And I would want you to look at these highlighted words, which is your interpretation and the facts. So we have to look at the facts and not what someone else tells us. And you have to make those interpretations yourself. And then finally, you must recognize elements of uncertainty. So what it means is that in medicine, nothing is absolutely certain. The only thing which is certain is that all of us, including our patients, will eventually die. But in a diagnosis, there is always uncertainty. And so we go through a process of making differential diagnosis. So what this process of making differential diagnosis is basically playing the odds. Like you play a slot machine, or you play various card games. So you count the cards and you make a judgment of what is most likely to happen. So you basically assess the relative chance that a patient is or is not suffering from a particular illness. So nothing is completely ruled out or nothing is completely ruled in, but it is just a matter of odds. The odds might be 99.9% or the odds may be 2%, but the odds being 2% doesn't mean that they are zero. So what are the elements of a clinical encounter when we talk to a patient? We look at three things. What is the problem of the patient? What are the potential solutions to this problem? And finally, what is the best solution for this patient? I think this last point is very important and needs to be emphasized, because quite often we read in books or journals a possible treatment for a given condition, but very often or almost on a daily basis, we need to tailor that treatment to any given patient. So even if there is a standard regime, you need to modify that regime either slightly or substantially for any given patient based on the risk benefit profile of that particular patient. So what are the important questions to ask? So the first question that you need to ask is that, does this particular clinical situation, on the basis of the history and physical examination, seem familiar to me? So, for example, if a patient comes to you with a history of high-grade fever, with a history of chest pain, with a history of bringing up productive green sputum, and you do a physical examination and find bronchial breathing on one side of the chest and crepitations, you immediately find yourself very familiar to the situation of dealing with a lobar pneumonia. But at the same time, you must ask the second question as well. What are the other possible explanations in this situation? For example, is there a possibility that something else could explain the same constellation of clinical features? For example, could it be obstruction of the bronchus, which has given rise to post obstructive collapse consolidation, and so on? Then the third question, what, if anything, do I need to rule out the really bad things, and how quickly does this need to be done? So, before making the diagnosis on a patient with chest pain, you do want to rule out immediately if the patient is suffering from myocardial infarction, because that is really bad and can kill the patient very quickly. And so, in that case, you realize that this needs to be done within a period of minutes. If we take a nephrology scenario, you may have a patient who comes to you with a history of not having passed urine in the last 48 hours. So the first thing you want to rule out is the patient suffering from hyperkalemia, and so you will prioritize that. Then once having ruled that out, you want to find out what is the possible cause for this renal failure. Is it a possible treatable cause? In which case you will take care of, say for example, RPGN and things like that. So once you have ruled out the really bad things, whatever you are left with, there are some remaining potential explanations, and there you need to decide: do you need to make use of additional tests to narrow down the list of your differential diagnosis? Then one important diagnostic test which you must always use is just simply the passage of time. For example, if you remember your neurology training, there was a very common dictum that if a patient comes to you with a history of some illness which has been around for more than 5 years, you can more or less make sure that this is a degenerative disorder. This cannot be an infective disorder. This cannot be a demyelinating disorder. This cannot be a tumor, but most likely it is a malignant disorder. Similarly, in patients with kidney disease, if a patient has a symptom which has gone on for 4 months, most likely it is going to be a chronic kidney disease. Then, of course, the next last two questions are related to treatment of the patient. So you will ask the question, does this condition require any specific therapy? And finally, very important, which we often forget, that does the patient understand what is the therapy which is required? Does the patient understand the risk benefit ratio? And is the patient on board with this particular plan? Okay, so then, how do we make clinical decisions? So clinical decision making is quite often analogous to the process of detective. So the detectives look for clues all the time, and decision making process can be done in three ways. One is called deduction, second is called induction, and the third is called abduction. Okay, so this is combined of, often people use the term hypothetico deductive. So this is what is the process. So what is the difference between these three? So deduction means starting from the general and going to the particular. Induction means starting from the particular and going to the general. And abduction means inference or an informed guess that fits the known facts. So let's take an example. Here is a jar of marbles, and you can see these are all white marbles, and you can see that there are some white marbles lying outside. So deduction, the process of deduction would say that all the marbles in the jar are white. These marbles have come from this jar, therefore these marbles must be white. So that is deduction. Now induction is starting from the other way, that by saying that these marbles have come from this jar, these marbles which are outside are white, therefore the marbles in the jar are white. Finally, abduction is more of an inference, which is what we do most of the time in clinical decision making. So the way the abduction process works is that these marbles in the jar are white, and the marbles which are lying outside are white, but we don't know for sure whether these marbles have come from here or not. So therefore we assume that these marbles are most likely to have come from this jar. So this is abduction. So this is an informed guess. Okay. So this is something which is for us to remember. So let's now come to data gathering. What are the first steps of data gathering? And once again, we go to Sherlock Holmes. So Sherlock Holmes said, it is a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories instead of using the theories to suit facts. And this is what happens very frequently when you know the diagnosis of a case. So what happens in that case is that you start to fit the history and physical examination to know the into the diagnosis that you know, instead of using the history and physical examination to make a diagnosis. So please keep a very open mind. Now, the next important thing is that when you are taking history, please remember that history is the remembered past, influenced by who does the remembering. And when we are taking the history, the remembering is usually done by the patient, because the patient is the one who's giving you the history. So the patients may interpret symptoms within their own frame of reference, and therefore you need to come out of that frame of reference and sometimes make your own observation. And again, coming back to Sir Arthur Conan Doyle and Sherlock Holmes, who said to his colleague Watson, who was a doctor, you see but you do not observe. So what we need to do is both to see and also to observe. So the process of observation is making inference from the facts that we have. So now let's go to the process of hypothesis. How do we generate a hypothesis? How do you make a differential diagnosis after you have collected the history, the physical examination, and so on? So the first thing is that we might just recognize a pattern. But please remember that oftentimes the pattern may be incomplete, and pattern recognition is a matter of experience. If you have not seen too many patients who fit within a pattern of disease, you will not be able to recognize a pattern. The more experienced you become, the more likely you are to recognize a pattern. So be careful in not to overdo this, at least in the initial stages of your training. The second case you want to do is to rule out the worst case scenarios, which, as I said, in the case of chest pain, could be heart attack. So this is a process of risk management, that you want to manage the risk. So in rapidly progressive renal failure, you may say that you want to rule out RPGN, because that is the worst case scenario, because you have a very narrow window of treatment. If you don't treat it at that time, that window would be closed. But the worst case scenario ruling out does not give you a diagnosis. The pattern recognition may give you a diagnosis, but the worst case scenario ruling out does not give you a diagnosis. Then the third strategy is what is known as the Casablanca strategy. So I don't know how many of you have seen the movie Casablanca, which had a very famous old movie, which had Humphrey Bogart in the lead role. So in which Humphrey Bogart is sitting in a cafe, and there is a crime that has taken place, and the sheriff or the police inspector says, round up all the usual suspects. So what we do here is just we order all the tests that you think will give you a diagnosis. So this is really a lazy application of a standard battery of tests. This means you're not applying your mind, and it is like working on an autopilot. So that doesn't differentiate between someone who's a smart thinking clinician and someone who has just read a book. So in this case, I think it is important for us to think of a thinking process. So how do we think? So there are two books which are interesting. One is this famous book by Malcolm Gladwell called Blink. So Blink is something that you first thing that strikes your mind. That could be the diagnosis. The second thinking process has been articulated by Professor Daniel Kahneman, who is a winner of the Nobel Prize in Medicine. He wrote a book called Thinking Fast and Slow. So he says that we have two inner systems of thinking. One is system one. So one makes rapid decisions, and system two is something which deliberates all the facts and then finally comes to a decision. So this is the process which if you take Daniel Kahneman's system 2, so this is how it will happen. So first, the basic process is the process of data gathering, which includes taking a history, doing a physical examination, and then thinking of what test to order. And using this data, then you generate a hypothesis. All right. And once you have generated a hypothesis, then you need to test this hypothesis. This you can do by asking some leading questions to confirm, at least from the patient, that whether your hunch is correct or not, and also by doing some directed diagnostic testing. And in my opinion, the next step is the one which is really very, very important, and which often many of you omit, which is the step of reflection and explanation. So once you have done the previous, you have done a history, you have done a physical examination, you have done hypothesis generation, you have tried to confirm it, then you must step away and think and reflect. And this is what in the process of, during the process of examination is called summarizing your case. Summarizing your case and coming up with a differential diagnosis. You must spend time over it. Even in an exam, if you think that you are running short of time, please do not cut short this step. Always ask for a few minutes extra from the examiner, and they will not stop you. Say that I just need to reflect and gather my thoughts before I am able to appear for the examination. Okay, so that's important. And then once you have done this, then you can arrive at your diagnosis. Very important. However, we all suffer from what is called a cognitive disposition to respond. So our cognition, it just wants to respond. So we gather some data which may be complete or incomplete, and we bypass the intermediate steps and often just try to jump at the diagnosis. So this process is this is known as heuristic process. So this sometimes you can do this by pattern recognition, and this can work. And so it may either be a diagnostic brilliance, that you make a brilliant diagnosis without going through all these steps by making a snap diagnosis, or it can be a diagnostic disaster also, which may cause you to fail in the exam, or when you are actually taking care of a patient, it may cause bad outcomes for a patient and land you in some sort of soup. So where does thinking go wrong? So there are three basic error types that we make. They can be divided into skill-based errors, which are slips and lapses. The second is rule-based errors, and the third is knowledge-based set of errors. So what are these type of mistakes? So slips and lapses or skill-based mistakes take place because we often get distracted, or we lapse into habits. So that occurs by being lazy. Then you have the rule-based mistakes, which can be misapplication of a good rule. So I'm sure many of you are familiar with these two rules. One is called Occam's razor, in which we should say that it is said that we should try to find the simplest explanation for any given cause. So when you try to always explain the patient's symptoms by one disease, but sometimes you can misapply it. And there is a bad rule which is called the Hickham's dictum. According to the Hickham's dictum, a patient can have as many conditions as he may want. So that is a bad rule. So if you apply that, you may be making a rule-based mistakes. Then you can have knowledge-based mistake. So knowledge-based mistake often happens from lack of information, because you are simply not familiar with, say, what is the differential diagnosis of RPGN, or from lack of understanding of logic, principles of logic. And what are the principles of logic? So they may be listed as necessary versus sufficient. So what are to make a diagnosis, we need both a necessary and a sufficient explanation for the patient's condition. So here is an example. So suppose there are two phenomena, phenomenon A and phenomenon B. So if phenomenon B is present, then A must be present too, though the presence of A does not necessarily imply that B will occur. So this is a necessary condition. So if phenomenon B is present, A is a necessary condition, but A is not sufficient to induce B. On the other hand, when we say that A necessarily implies the presence of B, but B could be caused by the presence of C. Thus, the presence of B does not mean that the A is necessarily present. Okay, so this is sufficient. So in this case, A is not A is sufficient for the presence of B, but B can also be caused by some other condition also. All right. So here is an example. Suppose you have a urine analysis in which you see this. So if you have looked at urine samples yourself, you will recognize that these are pus cells. So you will find there are lots of pus cells in the urine. So pus cells are for making a diagnosis of upper urinary tract infection. They are necessary. So you have to have pus cells for making a diagnosis of upper urinary tract infection, but they're not sufficient. However, when you have a patient who has come to you with history of fever and history of flank pain and dysuria, and when the urine shows this, then you are very easily able to make a diagnosis of acute pyelonephritis. All right. So this is an example of necessary and sufficient. So how does thinking go wrong? So thinking can go wrong at all these five or four steps of reaching a diagnosis. So at the step of data gathering, there could be faulty data gathering, which means either you did not take full history or you did not do entire clinical examination. So this is like slips and lapses. You lapsed, you slipped up, or you lapsed in doing something. Then you can actually do a faulty hypothesis generation, because there is a limitation in the knowledge. So these are knowledge based mistakes. So and we can do faulty hypothesis testing, and these could be mistakes which are based on rules. And then finally we can actually go wrong in the process of reflection and explanation also, because we either misapply a good rule or apply a bad rule, or we have knowledge based mistakes, and sometimes we may have biases. We sometimes try to become biased towards one diagnosis or the other, so there we may err in the process of reflection and explanation. And when these things happen, then possibly we may reach an incorrect diagnosis. So let's look at what are the biases and what are these cognition dispositions to respond. And these are all things which happen during the process of history taking and physical examination. So there is what is known as an order effect. So order effect means that we often pay more attention to the beginning or to the end, and we often miss what is happening in the middle. So please pay attention to all aspects of a case, and not only that the patient starts with some symptom and we immediately pay attention to it, or patient ends with some symptom and we pay attention to it. The second is, of course, what is known as availability heuristic. So something that is easily available is something which we try to. So we have seen some cases, three or four cases in the past, and so therefore that imagery or memory is fresh in our mind, and we immediately try to give the same label to the next patient also. The third bias is what is known as anchoring. So this is a sticky label. So we know this very well. So if a patient comes with a diagnosis which has been made by some other colleague, some sitting somewhere else, so that label often sticks. For example, it's so common to hear a resident present a known case of RPGN or a diagnosed case of acute renal failure. So that is an explanation of or example of a sticky label. So this is, this leads to what is known as diagnostic momentum, that there is a momentum now to that particular diagnosis. Now there is a confirmation bias also, because we have already in our head made an initial diagnosis and we are trying to search evidence to support that diagnosis. And sometimes we may reach a search satisfaction and prematurely close the diagnosis. An example of this is in a transplant patient who comes to you with fever and evidence of infection. If you find one infection, we close our diagnosis without realizing that a transplant patient can have more than one infection as well. Then there can be personal factors. Someone can be overconfident. There is often social bias. We tend to blame the patient and we say the patient didn't give me the history, without realizing that the mistake may be with us. There can be an outcome bias, in that we tend to make a diagnosis which has better outcome than a diagnosis which has poor outcome. Say for example, if you come across a case of RPGN and you have done a kidney biopsy, you find that there are 100% crescents, all of them are cellular crescents, and immunofluorescence shows anti-GBM disease. The diagnosis there is of course anti-GBM disease, but this, according to the information, this patient is not likely to recover. But we often make a diagnosis that these are cellular crescents, so perhaps this patient will recover, and so we should go and treat this patient. Okay. Now, the next important thing is what is known as base rate neglect. So, base rate neglect is that rare diagnosis occurs rarely. and a common diagnosis occurs commonly. So we often ignore the prevalence and make a rare diagnosis. For example, our anti-GBM disease, again taking the same example, it's a rare condition, so it is likely to occur less frequently. So making a clinical diagnosis of anti-GBM disease is a hazardous job. So if you ignore the prevalence and make that diagnosis, you will more often find yourself in a soup. And then what is known as the gambler's fallacy, which is a story of heads and tails. So often, if you take a coin and spin it, and 5 times it lands heads repeatedly, you are sure that the next time it is going to land on tails. But that is not how it works. I think you should remember that each case of head and tail is independent of what happened in the previous spin. So each time there is a 50% chance of it being head or tail. Okay. So please don't think that now that you have seen 4 cases of one, the fifth case cannot be the same. It could still be the same. And then finally, what is known as the posterior probability error, which is exactly the opposite of this. Just because you have seen 2 cases with a condition, the fourth case cannot have a different condition. So that is exactly the opposite of the gambler's fallacy. So how do you make a better decision? So the first thing you should do is to focus on task at hand by being mindful. So this is something which will come back to in a minute, but it basically means that you need to be really thoughtful about each step of the process that you are following. You should avoid working on autopilot. You should be aware of any distraction, and you must realize that there is significant impact of mood and environment. For example, I like seeing patient in a quiet room when there are not too many people around me distracting my attention. We can also make other types of errors, which is like data gathering errors. These errors can be pre-analytical, in which case, say for example, if a blood sample is mislabeled. So I think you should all be aware that errors can occur at all levels. So if you are getting a blood report which doesn't fit with the clinical picture of the patient, you should try to look for some of these errors. That there can be, was there any mix up in sampling, or was the sample analysis, there was a mistake in sample analysis, or after analysis, it has gone to the wrong patient's file, and so on and so forth. So you should be aware of all of these processes. So there is this theoretical thing in which we need to also think about our own thinking. This is important because only then can we safeguard our thinking process. So this provides you with insight into problems, and we become aware of our thinking process, which is known as metacognition. So meta is something about something else. All right. So we should reflect on our decision making, and we already talked about reflection. We should be aware of all our biases and all our system one errors, which means that we are prone to make some very quick errors if we don't do some deliberate thinking. And to avoid all of this, we can use what is known as cognitive forcing strategies. So cognitive forcing strategies are usually, they require structured review of data. So you look at your data and review in a very structured form by using checklists and using resources to decrease dependence on memory. So while not really necessarily valid for an examination, but nowadays you all have smartphones, and on your smartphones you have apps which tell you how to modify a drug dose for renal failure, to check what are the drug interactions before prescribing an agent. So you should use these resources to decrease dependence on your own memory. You should, and what I do during rounds is that you should make yourself accountable to the rest of the team. So even when I am taking rounds with the rest of my resident team, I don't think that I am so good that I can never make a mistake. So you should think out aloud. So you should try to discuss with your team what is your chain of thought, and if someone, your colleague, including your resident, challenges it, try to accept challenge and be willing to change your chain of thought. And what this does is that this allows us to develop skills in error recognition and allows us to recover from our mistakes. And I think in the end, it's very important, especially in the exam when you will be asked, how will you treat this patient? You have to ask yourself this question and then provide the answer. what is the best solution for this particular patient, not just the general guideline related solution. Okay. So what you need to be is not just a doctor, but you need to be a thinking and thoughtful doctor. So to do this, we come back to this. There is this famous book by Atul Gawande called the Checklist Manifesto. And for those who have read this book, will realize that the checklists were really developed by the airline industry for pilots to sort of go through a pre-flight checklist to reduce the possibility of errors. And Dr. Atul Gawande developed a checklist for the WHO for use in operation theaters. So, what boxes do you need to check in as a renal physician? So, I think when you are in an exam or when you are looking at a patient, these are the two main questions you need to answer. And if you have a checklist, mental checklist, in which you can actually try to check these boxes, then you will perhaps make very few mistakes. So, the first question is asking which part or parts of the kidney or urinary tract are involved. Is the disease in the collecting system? Can the disease be in the extrarenal blood vessels, such as renal artery, renal vein, or is the disease in renal parenchyma? Then you can again go through the different elements of renal parenchyma, starting from the glomerulus. And in glomerulus also you have different compartments like the endocapillary part and the extracapillary part, which is the crescent. You have to think of the tubule, you have to think of the interstitium, you have to think of the intrarenal vessels, which are the small vessels, and also the intrarenal collecting system. You can have diseases which involve the intrarenal blood vessels, like vasculitis or like thrombotic microangiopathies, or you can have diseases which can involve the intrarenal collecting system, like the collecting duct. You can have intratubular precipitation, intratubular obstruction, and so on and so forth. So I think if you create this list and go through this list in each case, you would have not missed anything. Now, once you have done this, then you should ask what can be the broad category or categories of illness. Is it a primary renal disease or is it a secondary disease? Which means, is there a systemic disease which is secondarily involved in the kidney? So the definition of a primary kidney disease is a disease which mainly involves the kidney. Primary doesn't mean that it involves only the kidneys. It can involve kidneys plus some other organs, but the primary presentation is with renal involvement. So the second question, for if you think that there is a secondary condition, is it a systemic condition or is it a renal limited condition, such as vasculitides? Okay. So once you have answered these, then you look at different categories. So is it an inflammatory disease? So in inflammatory condition, you can have two types of inflammation. You can have infectious diseases which also produce inflammation, and then you have non-infectious diseases like autoimmune diseases, etc., which are also inflammatory conditions. Then you have non-inflammatory diseases, which are, for example, toxic by use of drugs or by use of external toxins. You can have deposition disorders like amyloidosis, like Fabry's disease, like other types of fibrillary glomerulopathies. You can have light chain deposition disease, or you can have obstructive conditions. So these are also non-inflammatory. So obstructive conditions can be, for example, in the collecting system, or they can be in the intrarenal collecting system. Then you should try to answer this question: is it likely that this is a genetic or a syndromic disease? So look for known genetic conditions. Look for known syndromes. For example, you can given the correct clinical history, you can easily arrive at a diagnosis of autosomal dominant polycystic kidney disease. And similarly, you can look for specific syndromes. For example, if there is defect in finger, a number of fingers, if there is defect in nails, so you can have polydactyly syndrome, you can have nail patella syndrome, and so on. And then you should see if there is a neoplastic condition such as multiple myeloma or infiltration of the kidneys, and finally whether there is a degenerative condition. And in this degenerative conditions, there are not too many degenerative conditions which affect the kidneys, but there could be some like atherosclerosis, which is an age-related condition. So if you have a condition which you think might be involving external vessel such as renal artery, maybe atherosclerotic condition is something that might come to your mind. Okay, so I would like you to really look at this slide very carefully and really list these down. And whenever you are looking at any case, please go through this particular checklist. Now, next, you are always asked a question: what? How will you investigate this patient? Okay, so what are the rationale for? And quite often, many of you start by saying, "I will order routine investigations, CBC, kidney panel, so on and so forth," which is not helpful. Which again tells me that you are being lazy and adopting a Casablanca strategy, just doing everything that you have been told. So I will suggest that you should think of it in this way: will a test help you in reaching a diagnosis? Will a test help you determine the disease severity and or prognosis once you have arrived at a diagnosis? Will it help in deciding a treatment or choosing a particular treatment? Can the test be used for following up a patient? And does it add over what we already know? So I think if the answer of any test to any of these five questions is yes, then you should go ahead and say that you will order that particular test because it will help you reach a diagnosis or will help you decide treatment, or you want to use this as a baseline for following up the patient. Then the final question which is often asked to you is, how do you treat a patient? So in treating a patient, you must do, and I think the question which was raised before is that you must decide what is the best solution for this particular patient, not all patients with that disease, but that particular patient who is in front of you. So you have to do a risk benefit analysis. You must apply guidelines in the appropriate context, and you must indulge in what is known as shared decision making. So shared decision making is a process in which the physician shares the decision making process with the patient or the patient's family members who are in a position to make a judgment, so that they know what treatment you are prescribing, what are the benefits and risks. Because oftentimes when we decide a treatment, we think of the benefits of that particular treatment, but we often omit to think what risk it might pose. For example, again going back to the same example of a patient with anti-GBM disease who has 100% crescents, but they are all cellular crescents, you may say that I will treat this patient with pulse steroids and endoxin and plasmapheresis, but you must decide what is the likelihood of there being a benefit from this and what is the potential risk of this therapy. And if the risk benefit ratio is in favor of benefit, then you should go ahead and use that. Or if it is not in favor of the benefit but is heavily favoring risk, then perhaps it is not appropriate in giving that treatment, even though that seems apparent to you. Similarly, in another patient, if the patient has just come out of a very heavy infection, you may want to withhold immunosuppressive therapy. All right. So this is what